Hello, we'll be talking today about cauda equina syndrome, patient and public involvement in undergraduate medical education, and the Oxford Diagnostic pathway. And my name is Dr. Neil Dawson. I'm an emergency medicine consultant. What we'll be talking about on this presentation is the role of patient and public involvement, or PPI, in medical school. We'll spend the first few moments talking about the background of PPI, why the General Medical Council feels that it's important to form a part of medical education, and why we chose to introduce it in the Year 5 block in Oxford Medical School. We'll talk specifically about the PPI session with the cauda equina champions that we do in Oxford. We'll also share good practice about the cauda equina syndrome diagnostic pathway in Oxford and the Thames Valley. A bit about me. So I have been an emergency medicine consultant in Oxford University Hospital's NHS Foundation Trust since April 2016, so over 5 years. I'm also the director of the Year 5 Oxford Medical School 7-week rotation in orthopaedics, rheumatology, trauma and emergency medicine, which is known by the acronym ORTEM, O-R-T-E-M. I'm the facilitator of the cauda equina syndrome patient perspective virtual tutorial since 2020. The General Medical Council has issued guidance to UK medical schools about why PPI is important and why it's important to have it as part of your curriculum. They have said medical schools should ensure that a variety of innovative approaches to patient and public involvement and support is used. This would ensure that different experiences and areas of expertise of the local population are utilised, including groups that are usually hard to reach. Hard to reach groups may be patients with disability, or they may be patients who've had a condition that has meant that they've been in hospital and they've recovered and are then at home. So unless you actively sought these people out, then it'd be very hard to come across them in healthcare settings. Patients can contribute unique and invaluable expertise to teaching, feedback and assessment of medical students. The GMC talks about the concept of the expert patient. So these are patients with long-term conditions, and they often have extensive knowledge in various aspects of their condition, both in terms of the science and the pathophysiology of their condition, and also around day-to-day adaptations that they need to make to live with their condition. Expert patients are also able to offer insight into aspects of continuing and post-hospital care and interagency working. If you're a student who is coming across a patient in an outpatient clinic or on a ward, you'll see a very narrow spectrum of what that condition means to that patient, whereas if you are specifically educated by an expert patient, they can detail all aspects of healthcare that they come into contact with, be it physiotherapists, pharmacists, carers, paramedics, GPs, and how those agencies work together. The GMC recognises the patient's right to influence the attributes possessed by newly qualified doctors, asking patients to volunteer to become partners in education as active teachers is advocated. What this means is that doctors alone shouldn't be the only ones who are setting the agenda for medical education, and it should involve the wider community, including patients. So what are the benefits to the medical student of PPI? PPI can develop communication skills of medical students. Patients can critique how a student is phrasing things that is maybe done in a judgmental way or an insensitive way, and can help the development of the students' communication skills. PPI can also help change professional attitudes. A student might have preconceptions about how a patient with a specific condition thinks, lives, and meeting someone who can explain things in a detailed way around all aspects of their life can often challenge those preconceptions and make students think about patients in a different way. PPI allows the student to see the whole picture. How is that condition affecting them on a day-to-day life? The PPI can also provide context to the learning material and motivate learners. If a student is only learning things out of a textbook, it can be very difficult to see how that actually translates to a real-life patient. And it provides motivation to learners around a subject and helps consolidate the learning in the clinical context. Are there benefits to the patient? Yes, research has shown that there is. A patient might have had a really positive experience with healthcare, and so they have a desire to improve services and give something back to say thank you for the treatment that they've received. Equally, the patient might have had a bad experience or a delay in treatment with their healthcare, and so involving themselves with medical education can be a form of catharsis for them to get things off their chest, and also improve things going forward for the next generation of doctors to see things differently and hopefully improve care for patients in the future. The patient can also have improved confidence and improved self-esteem because they're being listened to, and they feel that their voice is heard and it's an important voice. Cauda Equina Champions Charity volunteered to start a PPI session in the Oxford Medical School in 2020. This was a session that would take place in the orthopedics, rheumatology, trauma, emergency medicine block, which is within year 5, the penultimate year of Oxford Medical School. The way the 7-week block runs is we have a 1-week induction week at the start, which is tutorials, simulation sessions, lectures, and that is followed by 5 weeks of clinical placements within the emergency department, orthopedics, rheumatology and trauma, in theatres, ward areas, clinics. The final week of the block is a consolidation of learning block with case presentations, an exam, revision sessions, and we also thought it was appropriate to put the PPI virtual session in this week. By week 7, a lot of the students will have seen patients with low back pain and potentially Cauda Equina syndrome, and so they can relate their experiences in the clinical area with the patient experiences in the PPI session. In the block, there is a mandatory learning objective, which is to describe what Cauda Equina syndrome is, its presentation, diagnosis and management, understand the need for urgency in treatment. So we started in November 2020 in the middle of a lockdown. We had 2 patients with Cauda Equina syndrome who presented their personal stories live via Microsoft Teams to 28 students and a doctor acting as a facilitator. This was a PowerPoint presentation with embedded videos. The presentation summarized the clinical signs and symptoms of the condition. It talked about the diagnostics, treatment, and continuing disability after discharge from hospital. The presentation was followed by an opportunity for open discussion with a question and answer session with the patients. We asked for feedback from the students about how they felt the PPI session went. One student said, "The session was really valuable in providing a patient perspective on the hospital experience. Having their worries played down by staff, being sent home without a formal diagnosis, and having jargon thrown at them. It also highlighted the symptoms and signs of Cauda equina syndrome in a very personal way. I don't think I'll be forgetting the red flag signs or presenting symptoms after this." Another student said, "Very good integration of clinical teaching with personal experience." Another student said, "Interesting to see from a patient's perspective, especially with how their presentations of Cauda equina varied and how this results in dismissal of their symptoms by healthcare professionals." I found that point very interesting because the student had perhaps thought that Cauda equina syndrome was one condition that only presented in one manner, whereas there's a spectrum of presenting symptoms that could be the first signs of Cauda equina syndrome, and so it opened their eyes into thinking more broadly. Another student said, "That was incredibly insightful. Not every patient wants to be a spokesperson for a debilitating condition, and the hospital isn't always the right time to have these bigger conversations, especially if they are just receiving the diagnosis then." Again, that's a very interesting point, which highlights the fact that often even for patients in the acute setting, they also need time to gain perspective and objectivity in their condition and in their treatment in hospital. And so it can be easier talking about that whenever they're at home and they've convalesced and made a recovery or have recovered some function following their condition. Another student has said, "Very moving stories, very helpful session, and really glad we were able to hear more about this serious condition. It's definitely changed the way I will approach back pain as a presentation." There were some small amounts of negative feedback as well, generally around wanting to, given that most patients who present to the GP or emergency departments with low back pain will not have Cauda equina syndrome, they would have liked more information given about how to manage a patient with simple low back pain. For the new academic year in 2021-2022, we decided to make some changes to the PPI format. It was recognised that with 28 students on an online video chat, it was hard to stimulate interactivity. Some students also had their personal video cameras switched off, so you couldn't even see what they looked like, and it wasn't entirely clear who was talking to who. We moved to a pre-recorded lecture with 2 Cauda equina syndrome patients talking about their personal journey and the clinical symptoms and signs of the condition, diagnostics, treatment. During the lecture, there were questions that were posed to the students around history taking and communication, and that was done to maintain attention. The students would then write their answers down, and in the live Q&A session afterwards, they would respond to the questions posed, and this should stimulate discussion points. During the live Q&A, the student could also ask the patients personal questions about their illness and about their recovery. The pre-recorded lecture will always be available to students on the online learning platform, although it's preferred that they watch the video immediately before the Q&A so as they can have it fresh in their minds about what the patients experienced. Now we're going to talk about the Cauda equina syndrome pathway within Oxfordshire and the Thames Valley. We have one neurosurgical centre, which is the John Radcliffe Hospital in Oxford. This hospital has 24/7 emergency MRI for patients with potential Cauda equina syndrome. We have one other hospital within the trust in Oxfordshire called the Horton Hospital in Banbury, and that has access to MRI until 7 p.m. 7 days a week. We have 5 other hospitals that are hospitals that can do MRIs during the daytime, but out of hours they would have to refer to Oxfordshire. These hospitals are Milton Keynes, Stoke Mandeville, Royal Berkshire, Wexham Park and Great Western Hospital. If a patient presents to their GP with back pain and symptoms suggestive of Cauda equina syndrome, they're referred to their local hospital emergency department. Within Oxfordshire, so that's the John Radcliffe Hospital and the Horton Hospital, ED takes responsibility for assessing the patient and organising diagnostic scans, whether the patient has come to the ED via a GP referral or if they've self-presented. If Cauda equina syndrome is confirmed, neurosurgeons are responsible for operating 24 hours a day, 7 days a week. If it's not Cauda equina syndrome, but an abnormality is found that requires specialist input, neurosurgeons will review the scan out of hours, and spinal surgeons can be consulted during the daytime to come up with a plan. The patients remain under ED care until that specialist plan is in place. If a patient presents to a hospital within the network outside of Oxford and they need out of hours imaging, they're admitted to a neurosciences bed in the John Radcliffe Hospital for a scan, and they shouldn't go through ED. There are many positives to the Oxford pathway of diagnosing potential Cauda equina syndrome. First of all, there's no ambiguity of responsibility for diagnostics. ED will organise the diagnostics and provide pain relief very quickly and refer on to the appropriate specialist team with the MRI results. There's also no ambiguity of responsibility for treatment. Neurosurgeons are the first port of call 24/7. We have a very good relationship with the radiology department, and we don't get any pushback about vetting and performing emergency MRI lumbosacral spines with a good story for Cauda equina syndrome. There are some negatives to the pathway. Because the patients with potential Cauda equina syndrome remain under ED care, they can often remain in the emergency department for many hours until they've been accepted by an admitting specialty. Providing continuing care with pain relief and bladder care can often be quite challenging in terms of resources in the face of record numbers of ED attendances, as opposed to being moved directly to a specialist ward. Another potential problem can be if there's no beds in the neurosciences bed in the John Radcliffe Hospital, where do the patients from the local hospitals who need the emergency MRI done in the neurosurgical centre go? Often they might have to go to ED if there's no beds available in the neurosciences ward. In summary, we've talked about the importance of patient and public involvement in undergraduate medical education generally. We have summarised the PPI Cauda equina syndrome session that we do within year 5 of Oxford Medical School in the orthopedics, rheumatology and emergency medicine block. We've summarised the pathway for patients with potential cauda equina syndrome within Oxford and the Thames Valley. Thank you.